are going to see the evaluation and management of a patient with suspected pulmonary embolism. First, we need to stabilize the patient with oxygen and IV fluids. Next, we are going to the diagnostic criteria. We have Wells criteria. This is 3 points, 1.5 points, and 1 point. We have two parameters that will give us 3 points. This will be if the patient has the symptoms of pulmonary embolism that are pleuritic, chest pain, dyspnea, palpitations, increased heart rate, tachypnea, sometimes a rough that we will listen due to pleural effusion, and hemoptysis. The hemoptysis will indicate a lung infarction. So symptoms, or if the pulmonary embolism is the most probable diagnosis. 1.5 points, we have 3 parameters that are if the patient have had a previous pulmonary embolism or deep vein thrombosis, if the patient has immobilization by more than 3 days, or recent surgery in the past 3 months surgery, or if the patient has tachycardia, more than 100 beats per minute. 1 point are 2 parameters. These are if the patient has a malignancy due to the hypercoagulable state that malignancy can produce, or if the patient have hemoptysis. The hemoptysis indicates the lung infarction that is rarely seen in patients with pulmonary embolism. Alright, so this is Wells criteria. If we have less than 4 points, it is unlikely that the patient has pulmonary embolism. If we have more than 4 points, it is likely. This is the simple way, but we could also do it like in mild risk, moderate risk, and severe risk. Mild risk will be for a less than 2 points, moderate between 2 and 6, and more than 6 will be severe risk. So first, after we have stabilized the patient, then we ask, is there any contraindication to coagulate IV the patient? If yes, if there is a contraindication, yes. Next, we need to do the diagnosis evaluation, and I'm going to do this in a second. But if it is a confirmed pulmonary embolism, then because we cannot treat it with anticoagulation therapy, we give or we put a inferior vena cava filter. And if it is excluded, there is no further evaluation. Now, if there are no contraindications, no. Now it depends if the patient has a unlikely or likely risk of having pulmonary embolism, or if it is mild, moderate, or severe. Here we will put high, and here mild or moderate. Now, if it is high, we begin anticoagulation before having the diagnosis. And next we continue with the diagnosis evaluation. If it is mild or moderate, we first do diagnosis. But if it is going to take a long time to have the diagnosis, let's say more than 4 hours, next in that case, we first do the anticoagulation. Now, in the diagnosis criteria, if it is a confirmed pulmonary embolism, then we continue to give the anticoagulation. That is, if we were here, or if we were here and we got a long time, and so we give the anticoagulation, and now we confirm that the patient has a pulmonary embolism, we continue to give the anticoagulation. Or if we were here and let's say just past 2 hours, we do the diagnostic evaluation. So, and there is a pulmonary embolism, then we add the anticoagulation. And sometimes we can consider surgery for the pulmonary embolism. But if there is no confirmation or if it is excluded, next we need to remove the anticoagulation if we give it in any way of the cases, or if we haven't done it, then we do not need to do anything else. Now, in the diagnosis evaluation, it depends on the risk of the patient. If the patient has a likely probability of having the pulmonary embolism, the diagnosis test will be to do a CT scan, a contrast with CT scan. If we cannot do this, we will do the BQ scan. So this will be, we have a Wells criteria greater than 4. And if it is unlikely, if we have a Wells criteria less than 4, next we do the levels of the dimers, the products of breakdown of fibrinogen. If the dimers are greater than 5 nanograms per milliliter, then this is positive, and next we need to confirm it with the CT scan or the BQ. But if it is less than 500 nanograms per milliliter, then it is excluded. So here, for example, we have there is contraindication to do coagulation. So the diagnosis, if the patient has a Wells criteria greater than 4, we do CT scan. If it is confirmed, we do IVC filter. If it is not confirmed, we do not do anything else. If the patient has a unlikely probability of having pulmonary embolism, next we do the dimers. If they are less than 500, no further evaluation. If they are greater than 500, then the CT scan. If the CT scan is negative, no further evaluation. But if the CT scan is positive or the BQ scan is positive, we do IVC filter. Here there is no contraindication, so if it is high suspicion, anticoagulation. If it is mild to moderate and is going to take a long, anticoagulation. If it is quickly the diagnosis, so we continue to the diagnosis. If here we came from here and it is so likely, we do CT scan. If it is negative, no further evaluation, and we need to remove the anticoagulation. If it is positive, we continue the anticoagulation. Now, if it is mild or moderate, if we give the anticoagulation, so it's the same. If in the diagnosis we have that the dimers are greater than 500, then we do the CT scan. If the CT scan is negative, remove the anticoagulation. If the CT scan is positive, continue anticoagulation. If the patient has not gone to the anticoagulation and directly to the diagnosis, so now if the D-dimers are negative, no further evaluation. If the D-dimers are positive, the CT scan. If the CT scan is positive, we add the anticoagulation. The anticoagulation therapy could be unfractionated heparin or subcutaneous low molecular weight heparin, subcutaneous fundaparinux, or direct inhibitors of factor 10, activated factor 10, that is rivaroxaban or apixaban. If a patient has a chronic kidney failure, we prefer to give the subcutaneous low molecular weight heparin. And in pregnant patients, we also prefer to give the low molecular weight heparin, and warfarin will be contraindicated in pregnant patients.